pleasure to introduce you to Dr. Khan. His talk today is titled ECMO from an Intensivist Point of View. Dr. Khan was born in India and graduated from the Bangalore Medical College and Research Institute. He then completed his residency in pediatrics at the University of Buffalo, New York, and he followed his fellowship in pediatric critical care at the University of Iowa. He joined Presbyterian Hospital in 2012 and currently serves as a program medical director for pediatric and adult ECMO program. He is also the medical director for both the pediatric and cardiac intensive care units. His academic interests include CRT in ECMO, ECPR, and he also very much enjoys ICU monitoring in congenital heart disease patients. In his free time, he enjoys traveling, he enjoys real estate, and he enjoys reading. Welcome, Dr. Khan.
Thank you, Kerry. Good afternoon and welcome, everyone. Thank you for joining us. Today's talk or discussion is mostly to learn from each other how we manage COVID ECMO or CAR. Basically, we go ahead and get started. Okay. Can you guys see the slides? Okay.
Yes.
All right.
Yes.
Thank you. Okay. So our topic is basically all of us are probably cannulated patients for ECMO, and mainly patients with COVID ECMO in the last couple of years. The question is, how do we get them off ECMO? How do we get the process of decannulation expedited? Well, let's see. So these are the topics that we are talking about that I'm really interested in talking about today. Candidacy for ECMO, timing of ECMO initiation, cannulation for ECMO. So candidacy for ECMO itself, it's a huge topic. Depends on the resources, depends on what time during the pandemic you're offering this therapy. So if you have, let's say, 2 ECMO machines and you have 5 candidates who need ECMO, you'll have to ration the care. So that's something that also has guided us in terms of helping us out, figure out who's a good candidate and who's not. And that has been changing all along. The timing of ECMO initiation, obviously any patient who is needing ECMO, you have to determine what is the right time to initiate it. You have to obviously exhaust all your other techniques that you offer to these patients to manage their ARDS. And then if that doesn't help, obviously ECMO is something that you can offer. Cannulation for ECMO itself, one of the things that we always discuss is what are the sites that are available to us and how can we optimize flows in these patients. I think placing somebody on ECMO, you can't have an afterthought that we should have done this or that. So that's something that we need to map the vessels, figure out what kind of configuration works best for the patient. We started off with north-south, and then we went to fem-fem sometimes. We've had BVA cannulations, and then lately we've done dual lumen cannulas with Protect Deos and all the other cannulas that are out there. Maintenance of circuit, obviously these are not runs that are like 4 to 5 day long. So you have to pay attention to maintaining the circuits as long as possible. And obviously the challenges that we've seen are anytime there's a circuit change, there is an inflammatory response that follows that. And we want to minimize those because that kind of sets us back by a few days every time that happens. So maintenance of circuit is very important. Obviously, all of us have had issues with air leaks, basically air entrainment into the circuits, clotting in the circuits, infection, and all that. So we'll talk a little bit more about that. Circuit change indications, it's somewhat clear cut, but depending on the availability of circuits, the availability of disposables, we've had challenges and we've essentially prolonged the use of some of those circuits for a longer period of time. Circuit DIC, obviously we see this as a complication of being on ECMO for too long, following an inflammatory response or an infection. The question is what kind of indicators you would use to determine that this patient indeed needs a circuit change. Infections, they have been a problem all along, mainly because these patients stay for so long. Something or the other is going to get them. One of them obviously being CLABSI, the others being ventilator-associated pneumonias. They're quite rampant. The incidence is quite high. depending on how you do things. I think it's an experienced center which is well oiled, they know what they're doing. The incidence is somewhat low, but if you have a unit where people don't know how to manage these circuits, people don't know how to take care of these circuits, then the infection incidence goes up significantly. So there are two components for this. One is monitoring for infection, like whether this patient actively getting infected or is it a false positive. And then when the infection happens, what is it that you have to do to maintain manage that patient, because they get quite sick into essentially septic shock and circulatory failure. So that's something that we've had as a challenge to manage these patients. The ARDS itself has been a challenge because all of us have learned a lot in the last 2 to 3 years on how these patients, how the ARDS evolves in these patients. We've guessed wrong. We would say that this patient started off okay and then they get sick. Some of the patients get super sick initially and then recover quickly. It's kind of hard to guess which of those patients get better faster. Right heart failure, again, this is one of the problems that it's hard to say or talk to the families and say your patient, the patient is going to do okay, because this is something that can get you anytime during the course of their ECMO run. Preventing it is very important. And then again, when it happens, how do we manage it? That's also very important. So the other questions on how to manage these patients on the ventilator, evaluating for VAP, evaluating for atelectasis or any kind of situation, whether you would bronch them or not to bronch them. Whether you bronch them, then the risk of infection goes high because of the aerosol spread. So when we first started off offering this therapy to these patients, to this patient population, the biggest fear people had were if we bronch them, we are going to get infected. At that time, there were no vaccines, and everybody in terms of healthcare providers were very afraid of offering this therapy. So we've had a few patients which we think in retrospect could have benefited from it. But as far as the trach is concerned, the biggest thing would be to liberate them from the ventilator as fast as possible. In order to do that, you have to minimize sedation. You have to make sure that the patient is strong enough to be able to tolerate coming out of the ventilator. So one of the things as a bridge that is offered is a tracheostomy, because with that, you can essentially wake the patient up and make some progress. The question is, what is the right time for tracheing? So we'll obviously in a short period of time review the literature on that and see if that helps. The other things that have come up lately is early extubation on ECMO. Basically, the patient's allowed to be on nasal cannula, high flow nasal cannula, and then never intubating these patients at all. That's one thing that is being offered at some centers. And then again, expediting recovery of, can we make any difference in the recovery of the lungs? Can we expedite it? That's a question that we need to ask. Then the other complications are air leaks that we've had. It could be in the form of pneumothorax, pneumomediastinum, and then in severe cases, it could be even emphysema, subcutaneous emphysema that could essentially cause problems. One of our patients developed significant subcu emphysema that was essentially compromising his circulation and his airway, and it needed to be mitigated with laceration of the skin. So those things can happen. As I said, like anything can happen on these patients, and then you have to react in a pinch of a moment. And then the next part is obviously rehabbing these patients, setting goals for rehab, making sure the team is involved in it, and then setting them up for lung transplant candidacy in case they're not able to come off ECMO. And this process is something that's a dynamic thing that needs to happen quickly, and then also has to happen efficiently. While you're doing all this, the patient's been on ECMO for a long time, the morale of the team is super low because they think that this patient's probably not going to make it. They've already developed some attachment to the patient and the family. Then that's something that you need to make sure that you work on that morale actively, because I think if you don't, then it leads to essentially, I would say, bad outcomes, because your team is not as involved, they're not as engaged, and letting it be the way it is not the right approach. So you have to take it head on and then manage that team morale. The other thing that came along during this course is Protectio and the other dual lumen ECMO cannulation techniques that essentially help us do RV to PA cannulation and essentially bypass the right ventricle to a great extent to prevent a failure. Looks like there are a few centers that have done this and have had great outcomes. We haven't been able to reproduce that, but I'm not saying that that's not true. So the other centers may have had more success. That's something that we experimented with at our center. The other thing would be to minimize or mitigate the hyperinflammatory response that happens once these patients go on ECMO while they have a COVID already in place. So the question is, how do we mitigate that? One of them would be to use Cytosol. There are some studies to support it. More and more centers are using Cytosol to mute the inflammatory response and clear the cytokines. We haven't personally used that. We have thought about exploring that. The other center that I've talked to have used high volume CRRT, and that is early on in the course. As soon as you cannulate for ECMO, these patients go on for a couple of days of high volume CRRT, mainly to remove the cytokine response. So that's something they've had great success with. We haven't personally explored it except for one patient who had a great outcome. Managing bleeding complications on ECMO, obviously this is not fun, but you have to do that. It's an unnecessary annoyance. And this is something that more and more centers are shying away from aggressive anticoagulation and cutting back on that, and more so in VA cases. So again, that's something that we need to discuss. And then anticoagulation choices, we've come a long way from just straight heparin, using just ACTs, to more specific measures of measuring anticoagulation. There have been bivalidurine protocols, kind of back and forth between heparin and bivalidurine, and other choices out there. Managing sedation on ECMO, huge problem, because these patients want to move. You want to make sure the cannulas don't move and the patient remains supported. The obvious complications on not sedating them adequately is that these patients get decannulated accidentally, and that can be a problem. So what is the optimal sedation, and how do we minimize the need for sedation? That's something that's been a huge challenge. The way we have dealt with it is to obviously extubate these patients over time, and then essentially offer a tracheostomy later on in the course. As far as sedation needs are concerned, I think sometimes they are overestimated, mainly by bedside nurses who want the patient to be comfortable. But I think there has to be an active involvement from the team to try to make sure that you minimize it and wake the patient up, because an awake patient who's cooperating with you in rehab is the best patient you can have, and that'll have the best outcome. Managing fluid overload during long runs of ECMO, that's an important topic, because I think all of us, as soon as the patient stabilizes on ECMO, we are like happy that things are going fine. We don't pay attention to the day-to-day fluid balance issues. We don't tweak things. We don't make changes. Some patient may be getting iatrogenic fluid overload. We don't pick up on that in time, and then patient ends up getting adversely affected. Obviously, there's data to prove that fluid overload itself is an independent risk factor for mortality. So anytime you reach 10 to 20% fluid overload, then your mortality rate goes up. So that's something that we have been closely watching at our center. Managing obstetrical patients, obviously, we haven't had any pregnant patients, but mostly postpartum patients. Their outcomes based on the studies are quite good. And this applies to even pre-COVID ECMO for ARDS, and that's from the during the time H1N1 was prevalent, they've had great outcomes. Discontinuation of ECMO for futility is a huge ethical, moral kind of a dilemma. Again, a patient who's awake looking at you is not progressing according to your goals. Again, offering withdrawal of support in those patients can be quite challenging and difficult. Weaning and decannulation, obviously the best part. All of us have kind of moved towards trying to offer capping trials for sometimes extended period of time, just to make sure we're not guessing wrong, and then decannulation followed by some amount of anticoagulation in the mix, just to make sure they don't develop any DVTs. Bridge to lung transplantation is a huge topic. I'm thankful to all the lung transplant centers that are out there that offer support to these patients. Again, candidacy is very important in that. You have to make sure that all the criteria are met. There is a very good vetting process in place. If a patient needs it, then have to meet criteria before you send these patients out for lung transplantation. And again, just because you send them out doesn't mean that there's a guarantee that they're getting a set of lungs. So anything can happen. They could be deemed unfit for transplant. So having said that, I just wanted to go back and review the literature, review what are the guidelines out there to help us understand this a little bit better. What are the unique features of COVID ECMO? So this is basically called as CARDS or CARDS these days. What exactly is happening in these patients? There's a profound cytokine storm. It's huge. There's some variation in how severe this is in different patients, but invariably we have seen that it's somewhat profound. The activation of the coagulation pathways in the pulmonary circulation is huge. There are different patients who have different lung involvement, which is called as phenotypic diversity. There are therapeutics that make secondary infections more common in these patients. Again, this is like a necessary evil, like a steroid course, or kind of immunosuppression you're using for any reason. So these things are important. Many of these characteristics, they do cross-react with what ECMO is doing to the patient in terms of hematological dysfunction, in terms of causing an inflammatory response, in terms of increasing the susceptibility to infection. So all these things are having it's a complex interplay. So you have to navigate the patient through all these things and try to help them survive this. So there is some preliminary evidence on how this may translate clinically, mainly with COVID ARDS, increasing the risk of thrombotic ECMO circuit complications. So anytime you have a therapy that you're offering, you want to make sure that since it's a very complicated therapy fraught with complications and obviously high cost, you want to make sure that the patient has met criteria for the therapy. Otherwise, it becomes too chaotic. Patients who may not need it are getting offered this treatment. So based on that, this is essentially an algorithm that's followed by most places. So what you're trying to do is, if you have a patient who meets criteria for ARDS, you obviously have to provide the standard lung protective ventilation strategy. You have to make sure the lungs are dry and you have resuscitated them appropriately. And despite all these measures, if your PF ratio is less than 150, then you have to progress to other techniques that you're using, prone positioning that is significantly used. And obviously in the first 48 to 72 hours, there's evidence to support neuromuscular blockade helps. You're using a high peak strategy, you're recruiting their lungs, you're providing inhaled pulmonary vasodilators. Despite all this, if this patient remains hypoxemic for multiple hours or is not able to ventilate or is acidemic, then you have to either decide if this patient has any contraindications to ECMO or not. If this patient doesn't have any contraindication, you offer ECMO. So I just wanted to go through this to make sure that we all understand this, and I'm assuming all of you know about this. So what are the recommendations from ELSO on the intensive care issues? So first of all, ELSO has determined that VV ECMO may be utilized for these patients with severe respiratory failure. Again, their outcomes are essentially comparable to pre-pandemic VV ECMO outcomes on ARDS. And the other recommendation, VA ECMO also can be utilized in patients with severe cardiac failure and ECMO. However, the studies and the experience with this is quite limited. Mobile ECMO is feasible. You have to organize ECMO centers within a certain geographic region. So you're talking to each other, you're communicating, you're basically setting similar criteria for offering ECMO so it doesn't become confusing. So that's something that is being encouraged. Obviously, as capacity diminishes, you have to make sure that the contraindications are taken care of and you're not offering the patients who don't need it. Data submission is key because we all have to learn from them and do a better job. There is also this confusion about the anticoagulation targets because of this notion that COVID does increase your hypercoagulability risk. You have to anticoagulate them more, but there is no data to recommend going above the conventional goals. There is no data to recommend deviation from conventional practices like transfusion, thresholds, tracheostomy, et cetera, So just so everyone knows that just because somebody has COVID doesn't mean that you have to do things differently. Futility is important. You have to discuss it with the family and the decision makers, and that's something that is an active, dynamic process. Rarely children can require ECMO, mainly because of myocarditis or multi-system inflammatory disease. Again, patient selection is key, and then you have to still follow the conventional guidelines for that. So these are the recommendations for ECMO from ELSO. Basically, cannulation sites, the two sites that we talked about earlier, the VAV cannulation. Again, the VAV cannulation is challenging because most of the time these patients either have arrested, you go on VA and then you add the VV component, but some patients who are on VV have right heart failure, they end up becoming VAV candidates, or sometimes even left heart failure for various reasons. So again, this has been a little challenging at our center to offer them without any consequence. Then there's this VV dual lumen cannulas. The question is, if you place them too early, the problem we've had is like these patients end up needing higher flows, and we've not been able to offer that with the dual lumen cannulas. Again, these patients also end up having liver congestion, and they've had issues with late RV failures. Again, this is something that we're going to look into the studies and see how we could do things differently. All right. So these are basic points on what we need to be focusing on, the big ones actually, for managing strategy of procedure on ECMO. The one thing being mechanical ventilation. We talked about the low tidal volume, low pressure, trying to make sure that you support the lungs till they recover. Tracheostomy timing, again, percutaneous tracheostomy is the standard these days. Again, how do we make it safe? How do we do prone positioning on ECMO? Again, it's very resource intensive. Awake ECMO, again, this is something that I'm a big fan of because obviously patient participation is huge. Coagulopathy management, again, how do we manage clotting circuits? How do we monitor them, all that? Deep venous thrombosis, before going on ECMO, while on ECMO, you could get DVT that can cause essentially a P and catastrophic issues. Post decannulation, you can have a clot that can, again, put a wrench in your plans. Cytokine removal, we just talked about. Blood transfusions, hemodynamic monitoring, PPE use, membrane lungs, again, whether they are involved in spreading of the virus, again, there's no data to support that. Co-infections, again, are huge. So these can essentially increase the mortality. Rehab, so even if you've done everything, and if you haven't rehabbed the patient well, they're not candidates for lung transplant, or they just prolong hospitalization. So the question is, we are offering this therapy. Have there been studies lately that have supported the use of ECMO in this population? Does it even work? So based on that, this is a paper that came out in April of 2021. Basically, they looked at, this is a study that was done in Paris. 17 different centers or ICUs in Paris were involved in this. They looked at patients with severe ARDS related to ECMO, requiring ECMO. About 300 patients were involved. 55% of their patients were cannulated at another center and then brought to these centers. So it's almost like the smoke and wheel kind of a model. The median age was 52 years. They tried to maintain lung protective ventilation. Almost all of them needed renal replacement therapy of some form. The good thing is 46% of these patients survived at 90 days. And then the most common causes of death are multi-organ failure. Again, what they saw was patients who were intubated and then subsequently cannulated for ECMO within a few days. They had a much higher survival. Obviously, younger age, less than 48, was a huge predictor of survival. Again, renal injury was essentially a bad thing. And all of these centers were at least managing 30 cases a year. So obviously, there's something that comes with experience and team training and everything. So that's something that we need to remember. Again, there was no difference in survival between patients who came from a mobile ECMO or on-site ECMO initiation. So this is another paper that basically came out of the ELSO registry, looking at 1,000 patients in early 2020. This happened very early in the course. So again, these patients were placed on lung protective ventilation and prone positioning, etc. And then they saw that the median duration for these patients to go on ECMO was 4 days from intubation. 57% of these patients survived. So that is huge. So what we learned from these two studies is survival is somewhere around 50 to 55%, sometimes even 70% depending on the center. So that's a good thing. So you can continue offering this, even though it's long, so this is something that we took back to our nurses, our bedside nurses, perfusionists, specialists, making sure that the morale remains high. Then the study comes along, that's from 2020 in October. Basically, this happened in Chicago. There's a center that started doing this dual lumen cannulas that are placed in the right IJ, basically an RV to PA cannula, essentially protecting the right ventricle, seeing if the outcomes are better. For some reason, the outcomes ended up being extremely, they're extremely high survival. So these patients were hospitalized and then intubated, and then within 4 days of intubation, they were placed on ECMO. They remained on ECMO for less than 2 weeks before they were extubated, and then subsequently decannulated within a month. And then they were discharged home 2 weeks following that. So as you can see in these graphs, the survival was huge. Then the next question is, we talked a little bit about the Cytosol. It's basically a filter that's added to the ECMO circuit to remove the inflammatory markers. This got emergency use authorization from the FDA. Now the question is whether it works or not. So this is a study that was not a big study, but basically it was over a year between April 2020 and 2021. About 52 patients received BD ECMO plus Cytosol therapy. This happened at 5 different US centers. And they looked at the mortality. So ICU mortality was only 17%, which is quite different from what we see. This was at day 30. And at day 90, it was like 27, still extremely good. So what they looked at was, what are the blood, they looked at a few blood tests to see what exactly is different in survivors. So what they found was the D-dimer levels were extremely high. in patients who are non-survivors, closer to 20, versus patients who are survivors, which is closer to 2 to 3. So what they found was each one microgram per ml increase in the D-dimer level related to 32% increase in the risk of death, which was huge. So what they felt was Cytosol was something that could improve survival, and then more studies are needed for this. This is another study that is currently underway. It's called the Cytosol Study. Basically, what they looked at was, what they're looking at is a phase 2B multi-center prospective open-label randomized trial. They're recruiting patients from 7 different centers in Germany. And these are mostly adults, 18 to 80 is the age group. And they're looking at CRP, procalcitonin, and then patients with vasophilic shock are suspected to have a cytokine storm. Anybody who's needing a large amount of pressors that include norepinephrine. So they are included irrespective of indication for renal replacement therapy, whether they have an infection or not. So what they're looking at is within 24 hours meeting the inclusion criteria, patients are randomized to receive either the standard of care or standard of care and Cytosol. Basically, using a catheter for that, the exchange for the filters done every 24 hours. Let's see, the outcome that they're looking for is resolution of the shock. Secondary outcomes are mortality benefit, interleukin-6 levels, and need for mechanical ventilation, duration of mechanical ventilation, et cetera, et cetera. So I'm just looking forward to the study to see how this affects our management, because I think strongly that the inflammatory response that happens determines the course of the patient and the outcome of the patient. And there are ways to control it. We are using steroids, but I think there is a much more evolved way of doing this. Then the next question was, we would manage these patients, and then suddenly you find out they're infected with eclampsia, with a VAP, and then suddenly start deteriorating. They are in shock. They already have a pre-existing RV dysfunction. So it's unclear if it's RV failure or is it the infection. So the question is, how can we control these eclampsias? So we looked at this study that came out of China, basically in 2020. They basically, what they were doing is they would bathe the ECMO circuits, including the hubs, with chlorhexidine on a daily basis. They would spend quite a significant amount of time. But what they found out was there was a mortality benefit from doing this. So basically what they felt like the rates, not mortality, but more, not just mortality benefit, but incidence of bloodstream infections was quite different. So this was an uncontrolled before and after study, and they washed it with 2% chlorhexidine and 70% isopropyl alcohol. Basically all the exposed circuits were washed, their hubs were washed, and then they also did cultures of these circuits post ECMO. And out of the 1740 ECMO catheter days in about close to 200 patients, what they found was the incidence of bloodstream infection was close to 12 in 1,000 in patients with without the intervention versus only 2 per 1,000 ECMO catheter days in the patients in which there was an intervention made, and the p-value was quite significant in that. They also found that the hospital mortality was 41 or 42% versus 24%, almost half the mortality, and the p-value was quite significant for that, as you can see. Sepsis-related deaths were low, and then this significantly decreased during intervention. So again, this is something that we have implemented at our center, and we've had huge success with it. Basically, our CLAPSI rate, we didn't have a CLAPSI on ECMO for almost 5 months. Going from almost every patient getting CLAPSI to none for 5 months is a huge success. Now let's talk a little bit about the right ventricle. It's something that we don't understand very well. So data recently suggests that the RV injury in the context of this lung injury occurs in approximately 1 in 5 patients. That's huge. And when you get this, there's a threefold increase in your all-cause mortality. So this is something that gets our patient no matter how good of a job we do. So the question is, what is it that we're doing? We are offering these patients VA ECMO. We are reducing or reversing their hypoxemia, hypercapnia, or acidemia. But even then, why does the RV become unhappy? So the question is, even though you provide this, the RV injury can persist, and that can be something that can take out the patient. So as you can see in this slide, the ECMO day 1, the RV looks quite happy. And then later on, ECMO day 35, you can see the dilated RV with the septal flattening. So this is a sign that the RV is not happy. It's under a lot of stress. This is something that we see at the bedside all the time. And then the question is, what can we do to make it happier? So There are two studies. One of them, Lazary et al., they looked at basically the prevalence and prognostic value of echocardiogram in these patients with moderate to severe ARDS. Basically, they're doing echoes in these patients. They found that the right ventricular injury was quite common, and about almost 66%, and impaired RV function was around 28%. RV dilation prior to going to ECMO was an independent predictor of mortality, which is interesting because we do echoes on these patients to begin with. And if there's severe RV dysfunction, we tend to delay it. In more recent study, in another study that they found that post-cannulation RV injury is something that can also decrease survival significantly and prevent you from liberating them from ECMO. So what are the mechanisms? So all of us scratch our heads like, what is going on here? We have reduced everything to prevent lung trauma. We are protecting the RV, but putting them on ECMO. The question is, what could be the mechanisms that may be underlying the continued injury? So one of them is partial reversal of metabolic abnormalities. So I think we're probably not doing a great job with reversing it. The other component could be that there could be an ongoing pulmonary vascular dysregulation that we don't understand very well. That's more research is needed for that. There could be presence of untreated pulmonary embolism because it's very hard to find a pulmonary embolus in a patient on ECMO doing an echo with all the windows you need. Or there could be even microvascular thrombi that may be generating because of the procoagulant state. So it's very hard to know what's causing that. Again, some of these patients, as soon as we put them on ECMO, we feel like, oh, we need to protect the lungs, and we get them into a state of atelectasis. That itself can increase your PVR and cause RV dysfunction. Again, the other component is a continuous non-pulsatile flow through the tricuspid valve into the right ventricle. This is something that, again, has been postulated to be one of the more important or potential causative mechanisms. So all these are like notions from experts around the world. We just need more research. So I just needed to introduce this just so we know that there's a lot more to learn about this. Then pharmacologically, we manage these patients with some presses and inotropes. We use milrinone. We use pulmonary vasodilators. We have started transitioning now these patients to sildenafil. It seems to have worked well. The other non-pharmacologic therapies obviously are ultra-protective lung ventilation, optimizing the PEEP, prone ventilation, mechanical RV support is one of the big things. Again, some of these patients, if they show any sign of RV dysfunction, we've transitioned them to FEM to basically RV to PA ECMO cannulation with a dual lumen cannula. Again, the role for this, again, as I mentioned earlier, in two different studies, they've shown that it does help. One thing I wanted to bring to your attention is that they had used a bundle of care, which should, I think, ideally be implemented. One of them is early extubation. I think there's huge benefit to that. Early extubation, obviously, there is less fluid overload. The patient can talk to you, so you're not sedating them too much. And again, the infection risk from VAP goes down significantly. Early corticosteroid therapy, high-dose anticoagulation, which again, there's not much recommendation from ELSO, but this is something that they had followed. They had used inhaled pulmonary vasodilators, and they kept up on their diuretic use, mainly to keep the lungs dry. Their survival was obviously 73%. And then more recently, they came up with a similar study, but this time they compared with standard of care on mechanical ventilation versus ECMO with an RV to PA cannula. They found three-fourths survival benefit in ECMO patients. So all right, this is an overview of what happened. They looked at almost 3,500 patients, and then 80 patients went on ECMO, 115 were eligible for mechanical ventilation. So as you can see in this, there's similar timing between intubation and ECMO initiation, about 4 days, and then versus mechanical ventilation alone. So as you can see that in this picture, the survival for patients who went on ECMO is much higher compared to the ones that didn't go on ECMO. You can see this is a much more, I would say, impressive picture here. The blue line on the top picture shows the survival for ECMO patient. The mechanically ventilated patient, unfortunately, with the red line, whose survival was close to 30% alone. So again, these things have to be reproducible at other centers. This is something that we are struggling to do. And I think at some point we'll re-explore this option. One thing I also wanted to point out in their patient population, patients who were around 40 years of age for some reason had the best survival, and the same with the BMI. And I'm not sure why. I think even they don't know why. Pregnant patients, I mentioned earlier, this is basically a case series that looked at pregnant patients or postpartum patients who were supported with VV ECMO. Their survival was close to 80%, and this is something that we have seen similarly. I don't know what is protective in the mother that helps them survive this illness. We've had patients who have had very short runs, 25, 27 days, and they came off ECMO despite being extremely sick. Again, the information on this is quite limited. And then outcomes of extubated. So this is something that we are offering more and more to all our patients is awake ECMO, VV ECMO. Again, in this study, what they looked at was they included 62 patients. They required ECMO for close to 33 days. 3 patients got tracheostomy, but majority of the problem they had were bleeding and infection. And then ICU length of stay was close to 1.5 months. Over 51% of their patients are discharged to an acute rehab facility, and almost 1/4 of them are discharged home. Again, what they found was an impact of an awake ECMO approach and survival to hospital discharge. So as you can see, these patients, they did really well being awake, and they were able to manage their complications really well. The question is about the optimal tracheostomy. There are multiple articles that have looked at this. At this point, there is no benefit. In this study, they looked at a few patients. It's a single center case series. And we've looked at other multiple studies where essentially the impression is that early tracheostomy may not really help that much. Introducing it later on in the course, once they have stabilized in terms of their hemodynamic status and respiratory status, is probably key. Obviously, planning around a tracheostomy is very important. You don't want to cause bleeding or other complications. So it's best to just do it when they're not significantly anticoagulated. As far as I think I'll stop at that, and we can entertain questions or anything else, any comments.
Awesome. Thank you, Dr. Khan, for that. If you would stop sharing your screen, and I'll put up the Q&A slide up. Again, for discussion purposes, we're going to use a Q&A window. Please type in your questions in that window, and we will, our moderators will select the questions. And again, if you see a question that you very similar to yours, please go ahead and give a thumbs up so we'll move it up in the queue and we'll address that. All right, Becky, if you want to kick it off.
All right, thank you, Dr. Khan, for that presentation. Initially, it looks like there's a lot of interest in exploring the right heart failure and its causes. There's a little bit of a discussion right now if you think, if in your opinion, a single site dual lumen catheter and higher flows than necessary are causing problems for the right ventricle. And then do you see any correlation between unmanaged fluid overload and the likelihood of RV dysfunction?
Yeah, so that's a great question. I mean, so anytime you have a patient with fluid overload, there are multiple things that happen. Obviously, your pulmonary compliance goes down and your right ventricle is obviously stretched. And that applies the same with patients with pulmonary edema or pleural effusions. They're similar. So anytime you have that situation, you have to closely manage it and make sure that, so there is a component of both preload and afterload for the right ventricle, right? So the preload, obviously, you're trying to make sure you don't make them too dry, but at the same time, the afterload is managed by making these patients extremely dry, by making their lungs dry. So does that answer your question?
And do you have any tips on, fluid is always an issue on ECMO. Yeah. You know, we get them so dry and then we can't get flows. Do you have any insight into the proper balance and any tricks that you do there?
Sure. I think the biggest thing is obviously monitoring them very closely because what happens is sometimes we forget that fluid overload is an issue in a patient. We think this patient is stable on ECMO and let them be on it for a few days. But if you monitor that closely and you stay on top of your fluid balance by introducing different modalities, one of them that we normally use as a trick is a Lasix infusion. So you're not causing huge shifts in the intravascular volume status. You do sometimes albumin infusion in addition to the Lasix, although the evidence for that is not great, but at least the Lasix infusions do help us manage the fluid overload more effectively or efficiently without dropping the preload on the RV significantly. And then obviously, if they're not responding to all these, and if they're going to renal failure, you have to use CRRT and other techniques like HT. One of the things is obviously mobilizing the patient helps with the edema and the fluid overload component of it. So I think that's something that we use. The other thing would be to feed these patients early on. The enteral feeding does reduce fluid overload because you're not giving IV nutrition. You're more into the gut. You're doing most of the work. Does that answer your question?
There is a follow-up if we have time.
Sure.
It's from William Harris. He liked your answer about fluid overload, but he's interested in the kinetic dynamics of higher than needed flow to the right ventricle and if there's any associated RV failure for the single site lumen cannula where it's, or double lumen cannula where it's all returning to the same place.
So I think there is a flow limitation with these dual lumen cannulas. It's not like we can achieve high flow. So I think that itself is a protection against these patients. The challenges that we've had in patients with extreme ARDS or very severe ARDS is the flows that we get out of these cannulas is not able to maintain the oxygenation. So the RV is now still seeing deoxygenated blood. So that itself stresses it out is what the hypothesis is, something that needs to be studied better. Again, that's the hypoxic vasoconstriction that happens downstream from not giving fully oxygenated blood is something that continuously affects the RV. And that's what we've seen in patients who've been on it for a month or more.
We have another question here, Dr. Khan. What are your thoughts on high flow nasal cannula? If no trach, could it be used to recruit alveoli? How about BiPAP? Or if we did trach, how about trach paired with high flow? What are your thoughts of eliminating the vent and decreasing the chances of worsening a cytokine storm barotrauma? What do you think?
Sure, I think that's a great question. So the question you guys are asking is using high flow as a non-invasive modality to prevent infection from an invasive procedure like a trach or being intubated. I think we've tried that in a few of our patients and it seems to work well. Again, it all depends on when you offer that, right? So when you offer it in a hyperinflamed state where the lungs are getting wet, you're letting them become atelectatic. I don't think there is a huge benefit. It's very hard for a high flow cannula to actually recruit the lungs at that time. So I think there is an art to in keeping these patients intubated for a short period of time when this inflammatory response subsides. I think the best way is to try to mitigate this early on. So as soon as you go on ECMO, put them on you choose what you want, like a Cytosol, you want to do high volume CRRT, whatever it takes to reduce the inflammatory response. And then after that, you got to like come back. You're not removing any fluid, you're just at that time dialyzing these patients out of all the inflammatory markers. And that's something that some of the centers have done and had great success. The mortality is super low, like 30%, 40% at the most. So I think there is a lot of learning that we can do on how do we mitigate that inflammatory response when it first happens. Because once the inflammation has happened, it's very hard to recover from. It takes a long time to recover from that. And then during that period, it's obviously key to make sure that the RV is happy, your fluid status is not out of control. Coming back to high flow cannula, I think it's good, as I said, when the patient is not heavily dependent on oxygenation from both the ventilator as well as the circuit by using the dual lumen cannula. And keeping these patients, I think what we have learned from the centers at Chicago and Wisconsin is they have tolerated hypoxemia in these patients to even like 50s and 60s. I think Carlos can tell a little bit more about his experience here. Carlos, can you please talk about that?
Yeah, hi, thank you, Dr. Khan. You know, we had a patient actually that was sitting in the 30s and 40s for quite some time with a, normal lactate and doing just fine. His cognitive status was perfect. He was awake, he was extubated, and they can tolerate quite a bit. I don't see the benefit of pouring more gasoline onto the fire and basically creating more inflammation by using a high flow device or BiPAP or anything like that. It just when they're in a sick phase, there's just absolutely no benefit at all. Where it does come into play is kind of when you're towards the the recovery phase. And then you start seeing some benefit, and then you start seeing some recruitment, and you start seeing some, basically tipping of the scales from ECMO to, to that other device and supporting that patient. You start seeing some changes in gas exchange and everything else. So I don't think there's a benefit in the middle of it. And that's kind of what we saw. And that's why we were just kind of gravitating towards, not using, not intubating our patients, not tracheing them, not doing anything, and, doing that early extubation. Hopefully that answers your question.
Thank you, Carlos. I think the key is to keep these patients awake, strong, participating. So the negative pressure ventilation that comes with spontaneously ventilating does protect the lungs over time. Anything that we try to do in terms of positive pressure, obviously harmful over long periods of time. So that's something that we have to minimize, is to keep them awake and try to, even though they may not be doing much to begin with, eventually they will develop some degree of strength, and they will get there. Again, I want to say that it's kind of a fine balance between letting your lungs collapse and having the RV face the consequences of that, versus letting them be more awake, tolerating a little bit of atelectasis, and seeing how things go as they get stronger.
Yeah, and I will add, you have to do something to improve the PVR. Yes. So that's the other thing that comes with it. So if you let those lungs collapse completely, your PVR is going to be out of control, and it's going to cause you a lot of problems. So you got to have something in place to establish that forward flow.
Dr. Khan, we have another question here online. Do you have a preferred scoring method for qualifying patients for ECMO, or do you use more than one scoring method?
So Carlos can specify that a little bit more. I think we use the REST scores, and then I think we follow these patients to see if they are benefiting from the therapies they're offering with the REST scores.
Yeah, we keep it really simple. We kind of look at the PF ratio. We kind of look at the, the patient as a whole, and kind of, that's really our general approach. If the patient's on a bunch of pressors and their PF ratio is less than 80 for greater than 6 hours, then we just go ahead and put them on. We try to get them on pretty early.
Thanks, Carlos.
So we don't really utilize like the Murray score and all that kind of stuff, and
Yeah, and then the other thing that we have obviously accounted for using is the BiPAP time and intubation time. We're trying to minimize that at least like 5 to 7 days of a total accumulative of BiPAP time and intubation time before we offer it. And anybody who's been on BiPAP for a long period of time, they essentially end up doing poorly, even if we intubate them and offer ECMO. So that's something to keep in mind. Any significant positive pressure does cause lung injury and then the reversibility of lung. I think I have Dr. Qureshi. If you have any questions, we'd be happy to answer too.
I think you have to be a little bit careful with the scores, because you have to make sure that they're validated. And just to our knowledge, there's no international scoring system that is validated. So if you're going to use that as an ECMO inclusion or exclusion criteria, you would want to make sure that there is a validation process that you've gone through internally before you start to offer that as the be all and end all. Because as ECMO teams mature, you have to be very careful that that there is some validation, because people will be like, well, this person doesn't meet the scoring criteria, and we don't have something that is well validated as far as COVID ECMO goes. So you have to be a little bit careful with scoring systems. So we've tried to stay away from it as much as possible. I wanted to just come back. I'm sorry, I missed part of the discussion for the right heart failure part. There's a couple of pieces with right heart failure. There's some evidence about protecting the right heart with reducing the overall cardiac output, whether you do it by using beta blockers or you do it by keeping the patients cooler, or you do it, whichever way you want to reduce the heart rate and reduce the cardiac output. There is some protection benefit, but once RV failure has set in, then there's no benefit to that. So, we've talked about doing that. We've actually done that for a few of our patients to try and see if we can protect their RVs or not. And then the other piece is, I think a lot of people get focused on the RV per se, but you have to remember that the LV plays a very important part in that, and you have to make sure that there's no LV dysfunction. And one of the ways of doing that is to know what your veg pressures are. And I think if it's becoming doubtful as to why you're having RV failure despite protection and despite having decent saturations, despite having decent flows, and you're still running into trouble and your RVs, you feel like the RV is not doing well, you may want to look into the LV, because if your LV EDP is high, then that may be the other problem that you're dealing with.
Yep, thank you. And a question here for both of you, Dr. Khan and Dr. Qureshi. We have a question here from our good friend Luke from Iowa. He's asking regarding the conversation we just had about avoiding intubation in these ECMO patients. What do you think the trend's going to be, in the future with avoiding these patients, just putting them on ECMO before intubation?
So I think going towards having them not intubated. More and more, the data that's coming out and survival data, if you look at, and survival data is one thing to look at, but then you also have morbidity data to look at. And if the more and more you look at the morbidity data, the amount of morbidity that these patients have is much lower if they are not intubated. Their overall survival rates are better. Their overall time or length, on ECMO is better. And even though initially we saw a big bump in the amount of time they were spending on ECMO, what we're starting to see is if you get them in early, even before they get intubated, the chances that they'll spend a lot of time on ECMO is much smaller. And obviously the naysayers will always argue, do these patients even need ECMO? Well, all of us have seen the trajectory of these patients, and most of us can tell if a patient's going to need ECMO or not eventually. And we would argue that you may have one or two that may have not needed ECMO, but most of them would have needed ECMO. And overall, their survival is so much better. And the numbers they just talk for themselves, right? 80% survival means 4 out of 5 patients are going to survive. If you have an average 80% survival in a patient that had never been intubated, then that just speaks for itself. So the trend is moving more and more towards having patients cannulated before they get intubated.
And just to caution, it may not work always. Like some of our patients, we've tried not to intubate, the inflammatory response is so huge, they get permeedema, they just start coughing, and then your circuit starts not working. So in those cases, obviously you cannot offer it. But again, the key is early, minimizing the inflammatory response. I'm hoping that we will come up with strategies on how to minimize the inflammatory response to a point that the lungs are not affected as badly. I think that's where most of the effort should be placed on.
So I have another question here from Jacqueline, and this is a very, very good question and something that we've all kind of dealt with. So do you? Oops.
Oh, sorry, Carlos. I moved it over to answered too quick. If you go to answered,
okay.
you'll see it.
All right. Yeah, there we go. Okay. So she's asking if we have any suggestions for patients who have substance abuse issues. Usually it takes a lot of sedatives prior to cannulation to decrease their oxygen demand. And it seems to be harder to wake them up after because of higher IV sedative rates. Any ways to decrease the withdrawal symptoms with quick removal of sedative medications?
I think in general, any ICU patient with those issues, we have sometimes done a propofol washout. Sometimes we've done phenobarb and use other agents to sedate. Sometimes a lot of Presidex. About what is your experience? It's a challenge.
It is.
Yeah, it's clearly it comes with its challenges. The one thing, of course, that Irfan talked about was propofol washout, and that's been done. The other thing is also, recruiting the help of addiction medicine early. And if you have an addiction medicine service, they really tend to help quite a bit in these cases. And to transition them from, non-opioids or opioids, longer acting opioids definitely helps. So I think infusions are good in the short term, but, once you're getting into day 8, day 9, you really want to move on to longer acting stuff. And so that's where the addiction medicine teams really help. So if you can recruit them early, it always helps.
Thank you. I think we've had success using valproate. We've had some patients that we've used gabapentin. So you just have to get creative with the stuff. It's a cocktail of something or the other. But I think what I've realized in most cases is we overdo sedation. We should always challenge these patients with cutting back on the sedation as quickly as possible. Because keeping them sedated is very easy. You just throw a bunch of stuff and they're sedated and they comply with your ECMO run. But then that in the long run is quite detrimental to their outcomes. So as Abrar said, use the experts that are available and see how we can get them off.
Our institution in particular in the height of the pandemic actually was running out of sedation medications. So we had to think outside the box quite a bit. And, that's when we started using some psychiatric medications early on, as soon as the patient started coming in, and, just to try to hit it from to try to reduce the amount of sedation they were getting. Also, I think with the extubation, that kind of helped with that as well, and waking them up.
And I think one more overarching thing is the time. So as long as you can support them for a long period of time, most of these patients recover. So we get impatient once it goes into a 1 to 2 month run. We just had a patient that just got decannulated after almost 5 months. And
166 days.
160, yeah, 160. That's huge. And there are some centers that have even gone on longer. This is a young patient, so obviously, as you can see, there's a huge quality of life here that they gain. But the bottom line is to be patient with this disease. This is like any other ARDS. It's just that it takes longer to recover, and then it had its own host of complications from infection and hematologics, like clotting issues. So otherwise, I think essentially you just have to be patient.
Awesome. Thank you so much for that wonderful discussion and presentation. I'm going to move this slide over. This kind of concludes our webinar. We're just a minute over time. I just want to thank everyone for your attendance and participation. Thanks to Dr. Khan, and thank you, Dr. Qureshi, for joining us as well to share your experience with us. And thank you to the panelists for helping us moderate this session. Before we go, I want to share with you that our next webinar speaker is going to be Dr. David Fitzgerald. David is a good friend and a colleague, and is always well regarded in our perfusion community. He is the program director at the Medical University in South Carolina Perfusion School, and he will be presenting to us on a very popular and important topic surrounding goal-directed perfusion, oxygen delivery as a key indicator for adequate perfusion. So please keep your eyes out for that webinar announcement and register. With that, we conclude our presentation. Thank you for joining us. If you have any questions, there's some emails up here, and we'll be happy to follow up. So thank you and have a wonderful evening. Good night.